All right, at this point in the program, we're going to turn the microphone over to Dr. Jeff Berk, who will moderate and introduce the panel regarding sesamoiditis.
Hi, good afternoon. This is the panel on sesamoiditis, and first of all, I'd like to introduce the panel members. To the far right is Debbie Spike Pierce. She practices locally here in Lexington. Dwayne Rodgerson also practices here in Lexington. Next to him is Wayne McIllwraith. He's the one out-of-towner that's come in for this from California and other parts. And then Mike Hore, just to my left, who also practices locally. And I'm Jeff Berk. What I'd like to do is just give you a brief overview of what we're going to talk about today. We're talking about sesamoiditis, obviously. And I want to give you a brief definition of sesamoiditis, and then what we've done is each of the veterinarians here has put together a few cases with some radiographs and some ultrasound images, not to get too technical, but just to basically show you what it is that we're talking about when we're evaluating these horses. And I want to make this very practical for you. I want you to be able to go home with some take-home points that are applicable to what you do. Many of you are consigners here, and I'm sure this is a big issue for you, and it is for some buyers as well. So we want to try to get this as right for you as we possibly can. So we want to discuss at the end of this how sesamoiditis is relevant to not only soundness issues, but to sales issues, particularly for you as consigners. So, and then we'll have a period of questions also, but if we're moving right through this pretty well, I'll try to keep my eye open in case anybody does have a question. You're welcome to raise your hand while we're talking. So let's go ahead and get started. Of course, no, there we go. Okay. This case is one of my cases. They've put them in alphabetical order, so my name was the first one on the list. What you're seeing here is the left front ankle of a horse, and this was a horse as a yearling at Keeneland. And it presented with a full set of repository radiographs, and this particular x-ray shows the medial or the inside sesamoid of the left front ankle. And I hope you can see that. I'm looking at the monitors down here, but I hope that you can see that there are some dark areas within the bone, and what those are, those carry blood vessels. Those are vascular channels. And when we talk about sesamoiditis, one of the things that we talk about a lot is what those channels look like. Are they normal? Are they abnormal? Are they enlarged? And we try to characterize them. And I think before I go too far, I will call on the panel to tell us how they would characterize the look of that sesamoid. Anybody want to take it first? Debbie?
I'll take a stab at it, but can we turn the lights down? Is there a way to turn the overhead lights down just to see the radiographs better?
Maybe not.
Okay. Well, how I would call it, you can see the areas of the vascular canals are coming in, and from what I can see, they look like they're starting to get enlarged, which we made a grading scale on that, and if they're more than 2 millimeters, they're starting to get enlarged, which on a front medial sesamoid, if I'm looking at this, I'm going to want an ultrasound of the sesamoid, of the suspensory branch, where it attaches on the sesamoid to see if there's any changes, because that's going to help me make a decision just to help my buyer decide how much risk is involved with this particular case of sesamoiditis.
Okay, great. And comments? Mike?
I guess for me, it depends on... I don't know if it's working.
Just get a little closer to...
I guess for me, it depends on what time of year I'm looking at this. Right now, I'd call it mild sesamoiditis, but if this is March and a spring X-ray, survey X-rays, it's the kind of time we want to, take care of this and manage it properly. If your goal is to sell it in September or October, if I'm betting it as a yearling sale, I'm calling it mild sesamoiditis, and I'll tell my client I'd be pretty comfortable if I go and ultrasound this and it's normal. I'm pretty comfortable with you buying it. If there's any change on ultrasound, I would be somewhat scared of purchasing this horse. And the same goes for a 2-year-old sale. It all depends on the ultrasound scan. If that's normal, I'm comfortable with buying it. If there's any change in that, then I think you're going down a risky road.
Any other panel comments? Let me just back up for 1 second, because what I was wanting to do is give you a brief definition of sesamoiditis, and I think both Debbie and Michael have hit upon one of the really most important points about it. Sesamoiditis is very simply inflammation of the sesamoid bone. The significance of sesamoiditis, though, has less to do with the actual bone and more to do with the health of the suspensory ligament that attaches, the branch that attaches into that bone. And that is why we're talking about ultrasounding on these horses. Any negative consequences of sesamoiditis usually have less to do with the actual bone itself and more to do with the soft tissue structure, which is the branch of the suspensory ligament that attaches into it. So during the course of our conversation, you're going to see some ultrasound pictures, and you're going to get a feel for what is happening to the soft tissue. So we're really using these radiographs as a marker for a potential disease in the soft tissue there. So the reason I brought this case, I thought it was interesting, is because depending on how you look at those vascular channels might also determine how significant you feel that this is. And clearly the one on top is clearly enlarged. The others are sort of borderline, and this horse did have a normal ultrasound examination and subsequently went on to race not only successfully but very competitively in multiple grade 1 events. So, yes? I'm going to try to do it from here. That is your sesamoid bone there. There's your cannon bone. There's your first pastern bone. There's 2 sesamoids. This one is the medial or the inside sesamoid. We project it out by taking an oblique view. And this area that I'm highlighting with the pointer is where your suspensory branch attaches in, and that's a crucial area. And so these vascular channels are indicators that you've got a lot of inflammation going on there. So I would say that channel right there is pretty enlarged. These 2 are a little bit fainter. The ultrasound was normal, and fortunately for this particular buyer, this horse got purchased and is a known horse. So that's one example of why we want to be so careful to try to use every modality that we have to evaluate these, because there's only one thing worse for a veterinarian than missing something, and that is being overly critical and allowing top horses to go to other clients. And that's the flip side of what can happen that's not so good. So anyway, that one had a very happy outcome. I think you can see that. It's just enlarged. It's the same picture. And that's just another view of the ankle that we use to try to look at that area. And I think that you can see right up in there. You see those dark areas right up in there? That's the same thing. Those are the vascular channels. So, let's see, why is this not advancing? Oh, there we go. Okay. So this one, this is a second case. This is a filly that came into Keeneland at a November sale as a 2-year-old. And so she was a racing and broodmare prospect. And what you're looking at is that's the left front ankle, the lateral or outside sesamoid right here. And I think, oh, perfect, thanks. So we're looking at this area here, and could I get the panel to comment on this sesamoid?
For the sale, that's the big issue, is what this is going to look like at the sale, and that's, I think, why everybody's in here. As Mike said, I think there's two scenarios where you look at these in the spring, and I think that's one of the most important aspects of your survey radiographs, is to identify which horses actually have early signs of sesamoiditis, so you can then potentially protect these horses. Keep them light, minimize their turnout. They may not be able to keep up with the rest of the herd, they're pushing themselves, they're fatiguing, they're, in a sense, inflaming that bone tendon junction, therefore you get inflammation at that junction and you get bone breakdown. And we're seeing some of that bone breakdown in this particular sesamoid, and that's worrisome that you may actually have a true tear in that suspensory ligament, the branch, either inside or outside. So, as Mike said, we'd be worried about, you know, a tear, ultrasounding it at the sale. At the sale, you're also worried about what everybody else is going to say. And you'll see up here, you'll have different opinions amongst us all, where I may say it's mild, or I may say it's severe, and somebody may say it's mild. It varies considerably what everybody thinks of them and how they grade them, and it gets very foggy as far as how these horses are going to pan out at the sale. But this sesamoid, I would feel, would be discounted at the sale, so you'd be trying to forewarn your client that there's going to be vets that are going to call it moderate, even though I may call it mild. Be ready for them coming to the barn to ultrasound it, so you're prepared, so you don't think that we missed something. They're coming there to just do a thorough exam. So I'd be calling this mild to moderate sesamoiditis.
And as Dwayne said, there's a number of grading systems, but yeah, I would say that's more than mild, you know, certainly of concern. But you were grading it mild to moderate, but still calling it a major concern, weren't you?
I'd be, if the, you know, I'd be more concerned about the ligament. That's where I would be focusing on. And you'll see some from the slides here, that's what we're focused on. Is that ligament okay?
You know, one point that Jeff brought up initially and Dwayne's talking about is that when you can see those dark spots out at the periphery of that sesamoid, the periphery is where you've got the junction with the ligament. And the ultimate prediction issue with all of this is the horse going to get an insertional desmopathy or a suspensory ligament desmitis? Both terms are used, but we talk about an insertion desmopathy because that's where the suspensory branch attaches to the sesamoid bone. And it can give you an insight, but as was discussed before, the final analysis is done on ultrasound to really see what the condition of the ligament is. But certainly when you've got that degree of change in the bone at the perimeter, you've got to be concerned.
So I think that you can see that there's room for variation between how you would classify this, whether you'd call it mild, mild to moderate, moderate, but certainly everybody on the panel has expressed some concern that they'd have enough concern about the appearance of this that they'd want an ultrasound exam. And so here, let me make sure that that's the right, yes. That's, okay, that ultrasound corresponds to that area. And what you're looking at here, two different ways of looking at the same area. This is called a longitudinal or long scan, and this is a cross-sectional scan. You're just turning the probe two different ways and looking at the same area. What you're seeing here, this bright white line is the sesamoid bone, and everything coming across here is suspensory branch ligament. And you can see all this looks normal. This is what normal up here. This dark area in here and this little disruption at the bone surface, that is where the suspensory ligament inserts into the sesamoid bone, and that is basically combined with this. You can see the same view cut differently. You can see the hole in the middle there. That is a core lesion inside the suspensory branch, and it affects the branch attachment right there. So that's what we're talking about. In the first horse that you saw, the scan was totally normal, and it helped us to be more on the side of being comfortable with that horse. This horse had already been racing as far as the information that we could get, there was no history of unsoundness. But if you looked at this and you said, what are the odds, you'd have to say there's at least some chance that this is going to become clinical and affect the horse's soundness. One of the reasons that I picked this case is because I had the good fortune, well, at the time it seemed like bad fortune because I was working for both the seller and the buyer, so I had to be very careful to present this exactly the same to both people. The horse ended up not getting sold at Keeneland, went back to a training facility, and then within about 2 months had developed lameness referable to this. So in this case, the ultrasound helped us to determine which way to go, and on behalf of the buyer, it was the correct decision for them. So as you can see, the reason that I put both of these cases out is because both of these horses have sesamoiditis. It's not just as clear cut as if they have sesamoiditis, you don't buy it, and if they have sesamoiditis, you don't buy it, and if they don't have sesamoiditis, you do buy it. There's a lot of nuances here, and we're trying to take advantage of every imaging modality that we have to try to get a better, more accurate look at what's going on in the horse. Okay. This is just the other, this horse developed suspensory branch disease in both front, and the other sesamoid didn't even look that bad. It was, wait a second, that's, no, that is the other sesamoid that it developed. It developed sesamoiditis and suspensory branch disease subsequently. So you can see those are two what we'd call grossly enlarged vascular channels. They widen at the abaxial surface where the suspensory branch attaches, and I think that we'd agree that that would cause some concern there. Okay. Let me go back. Okay. This horse, actually, this is a third horse here, and this horse did not sell at Keeneland, was presented at the April sale, was kind of on and off lame, and then went on to develop full-blown clinical suspensory branch disease and did not race. Okay, Michael, we've got some of your cases up here.
Yeah, so this was a case of mine, a foal that was purchased in November as a weanling. You can see the sesamoid here. It's pretty normal. I didn't call anything. I told him it was fine and go ahead and buy it. So they purchased it, and we, as we routinely do, we x-rayed it again this spring. And he just started developing some sesamoiditis. You can see the 3 small vascular channels. So this is kind of at the point we jump in and try and prevent this from getting worse. So my kind of criteria with these horses is definitely limit their exercise, limit their turnout, keep them light, and just manage them. Look for any profile on the leg during the year. So we did that. We basically didn't use any drugs, and I know people are going to ask questions about aspirin, azoxypurin, Tildren, Adequan. Everyone wants to know about that stuff, but I can't give you an answer that any of the stuff works, to be honest. I've definitely used it all, but I've also seen horses come completely normal on nothing, so I don't think anybody can give you the answer to that right now. So as you can see, we kind of watch this horse all year.
So, Michael, while you're back to the isoxaprine, aspirin, all of those, so what is your preferred regimen? You didn't do anything.
We didn't do anything
with
the horse, no.
So when do you put them on aspirin or?
I don't, to be honest with you.
Oh, you don't? Okay.
Unless the client wants to or has got advice elsewhere, but I typically don't advise aspirin or azoxypurin. But as you can see, this horse ended up being normal in September and selling well with no complications. My second case is homebred, so we didn't have any previous x-rays on it. We x-rayed it in March. And Jeff, if you can just highlight the defect at the back of the sesamoid, the abaxial margin, you've got a dark area right there, so you get some bone reabsorption. Same scenario, if we took this horse to the sale today looking like that, it will be heavily discounted. So, you know, we did the same. We kept them light. We really limited their, I'm not saying lock them in a stall for 2 months, but we definitely limited them to a small paddock and different type of prep than the usual, you know, lunging and walkers and stuff. We definitely went a bit lighter and easier on that. And I don't have the x-rays here, but we kind of x-rayed it once a month, and it started to get better in July. We could see it was remodeling a little bit and evening out. So we decided to keep the horse till October, give it every chance it can to look as good as it can. And by October, it looked a lot better and, you know, passed the majority of vets and sold okay, you know. So my client was happy at the end of the day. And they don't all work out like that. You know, they can go different ways. This is another case of, this is a normal sesamoid, a hind sesamoid, inside sesamoid in the spring. Everything was normal, so we were happy just to continue a normal turnout, normal exercise. So we didn't revisit the horse till we x-rayed it for the sale, and you can see some channels developed here to the point where I was calling it moderate sesamoiditis. You know, they're bigger than 2 millimeters, they come to the surface, and so this horse was discounted in the sale. You know, ended up not selling, but, you know, I had a lot of action, apparently what I was told, but, you know, people didn't really want to live with this sesamoid, so, you know, I don't think you need to be a veterinarian to tell what happened next. When this horse eventually got up to breezing, he broke his sesamoid in half, and this was way after the injury. It's, you know, he developed a lot of arthritis and basically didn't have a career, so, you know, that's another way what can happen to some of these that don't go the right way, you know. You know, the ultrasound of this was pretty torn branches and it was pretty ugly.
The question was, did you ultrasound that year?
That horse was not ultrasounded, no. I didn't because I was working for the seller, but I'm sure people probably did at the time, yeah.
Any other comments from the panel?
And as far as the fracture that happened, that's not probably the normal.
Yeah.
I mean, this is, and it's a very interesting case, and I think it's great that you have this, but I don't think that that's something that we normally see as far as having the sesamoiditis and them fracturing. So I just wanted to let you guys know that. I mean, that's
yeah,
a
the
pretty
majority
severe
of
case.
cases I have that look like this in September, if you scan these and are normal, a lot of them do fine actually, and I've never be a problem. I'm just showing you an extreme case here. And I just have one other simple case, I think, with just some change. This was actually a 2-year-old at a 2-year-old sale. Had a proliferation on the back of that sesamoid and some sesamoiditis. We went ahead and ultrasounded it, and you can see the core lesion in the suspensory branch right here. So, you know, I kind of put my clients off it. I was pretty nervous about it, and I followed the horse racing, and it's ran a couple of times, but unsuccessful, and I think it's since been retired, so that's kind of, you know, my position on them is very strongly influenced by the ultrasound, especially at 2-year-old sales. If they have any lesions or any pathology, you know, I think you have to stay away from them.
Any comments before we go? Dwayne, you have the next group of cases, right?
Just while Dwayne's coming up there, Jeff, you know, I think it's important to, and you've implied it, but we know it's inexact. There have been a number of studies done looking at the correlation between the changes with different grading systems, as well as the follow-up results. But there's been a relatively recent paper that's consolidated the study that Dr. Spike Pierce, that Debbie did with Larry Bramlage, also looking at the grading system that we did in the study that was Al Kane and Dick Park and myself, as well as Rantanen, Moorhead and Bramlage. And then this most recent study, I think there's a couple of figures that people should be aware of from the point of view of horses were graded from 1 to 4. The sesamoiditis was graded from 1 to 4, with 1 being no sesamoiditis present. And when they looked at the training records and they looked at the first occurrence of clinical signs related to suspensory ligament branch, and the thing that was good about this most recent study, it was done in Ocala, but at the training centre, the clinical follow-up was very accurate. But there were 39 cases that developed suspensory desmitis of these horses that were radiographed, and 262 that did not develop suspensory desmitis. So the prevalence of suspensory desmitis was 9.97%. And the interesting situation with those is that of those horses, of those 39 horses that developed suspensory desmitis, 89% of the cases had sesamoiditis changes in at least 1 sesamoid. However, 22 of them, 75%, suffered from sesamoiditis greater than grade 1, which is, I think all of us would agree, grade 1 is normal. Obviously, there's no change. And so only 75% of them had any change in the sesamoid bone. So it's not a direct cause and effect, and that's what makes it so tricky for all of us when we're giving opinions. The other important thing is 25% of the horses that developed suspensory desmitis had normal radiographs all along through. So it just makes the point that there's other factors that are going to produce the disease that we're worried about, and that's what makes it really tricky when we're doing what we're doing now. I had to use my laptop because I can't remember the figures exactly.
All right, we're showing cases here, but sesamoiditis, as I said, is the vogue lesion. That's what everybody's worried about. And as we were going through all this, I kept saying by the end of it, we're all still going to be more confused than we started with because of the variation in opinions and the variation in the cases, how they present. And this first case is one where some farms are very astute as far as picking up profiles, looking at the fetlocks, looking for any change in profile. They're very good at just seeing a difference from one day to the next. And this particular case was an example of that. So if you look at this particular sesamoid, most of you have seen some of the bad ones, you're going to say, it looks pretty good. And you got to remember that they're going from a 150-pound foal to a 1,200-pound animal. And being in Lexington, Kentucky, our paddocks and our fields are quite small. If you got an individual, and that's the key word, individual, they're not all the same. And they're going to be turned out, and they're going to try to keep up with their buddies. And he may be an individual that likes to eat, and he's going to eat more than his other buddy, so he's heavier. So that weight is going to put more strain on that suspensory ligament. That horse is potentially more at risk to get sesamoiditis. That horse is more at risk to potentially tearing that suspensory branch. If you look at this sesamoid, it looks fairly normal, but this particular farm was astute, and they saw a bit of profile. And this is where we're looking, and you can kind of see those canals there. And as these horses grow and develop, almost a little bit of sesamoiditis you can kind of live with, because they're adding that extra weight. They're turned out in these big fields. They're putting a lot of strain. Those sesamoids are responding to that force, that tension that's being put on those bones. You almost expect a little bit of change. Now, granted, if we get severe enough inflammation, we get a tear, that's our concern. If you look here, this is the left front inside sesamoid, comparing it to the right front. They look fairly similar. And not every leg is not going to be exactly the same. Left and right is going to be different, just like in us. But if we go and we look at the ultrasound examination here, and this is, if I can get it to go here, both images, both planes, we have a longitudinal plane and we have a transverse plane. But if you look at this, because of that profile just around that sesamoid, those inside sesamoid, we have a tear. So here we have an individual that has fairly decent looking radiographs, very mild or very slight sesamoiditis, but we have a tear in the ligament. So sometimes they don't go hand in hand. I think that's what Dr. McIllwraith was saying. So if I have my pointer here, you can see on this longitudinal section, we have a change, a core lesion in this suspensory ligament, this inside branch. On the transverse section, we have an obvious core lesion. This horse actually went to the sale. The x-rays looked very good. The profile, once the edema, the inflammation came out of that suspensory branch, looked pretty good, but we still had an injured tendon, ligament. Same as a bow tendon. And if you know this as a yearling, if going to the sale and you got a yearling that's really well bred and you know you're going to get discounted greatly at the sale, you're going to protect that yearling. You're not going to start training it as a 2-year-old. You're going to try to protect it, ease it, focus on to the 3-year-old career. But if you buy this horse out of a sale and you don't know it has a branch injury and you go forward just like you would with a horse that doesn't have one and start training, just like any tendon injury, ligament injury, it has the risk to re-injure. Am I going backwards? Oh shit, I'm going backwards. Second case. This is one that's fairly obvious. I think everybody in the audience would be able to see the lesion. It's fairly large if you compare it to right to the left. This was found at sale time. If I asked the panel what they'd think about this, we discussed it beforehand. There's a difference in opinions, but I think most people at the sale, if you had to read what most veterinarians are going to say, they're going to discount this horse. They're going to fail it. So I got to be up front with the client and tell them, be ready for a discount at the sale. And I try to use discount as being nice, but really what I'm saying, they're going to fail it. So we have a large area of bone breakdown, inflammation in this inside sesamoid of the right front. I went ahead, when I x-rayed it that day, I went ahead and I ultrasounded it. And if you really follow the ligament, both in longitudinal planes and transverse planes, there's really not a core lesion. You have a little bit of edema, a little bit of fluid against the sesamoid, but there's no core lesion. So I know this horse. I know that there's no injury there. I actually passed this horse for a buyer that I do work for, and he bought the horse, but the horse was discounted. This horse, and I gave him instructions that, just as we talked about, it's a yearling. Don't focus on the 2-year-old career. And this guy's willing to do that. So he's not going to try to push this horse as a 2-year-old. He's going to wait for the 3-year-old. So 2 different scenarios where we have a sesamoid that's fairly normal and an ultrasound that's abnormal. And then the opposite here. In the last case, because we talk about front limbs all the time, I just wanted to tell you that it does come in the hind legs as well. Don't always focus on the profile of the front legs. Focus on the back legs as well. You'll see it there also. And you can see on this particular sesamoid here, we have changes on that abaxial surface. We have areas of bone breakdown. As well, what you can see, and it's not the best indicator for soft tissue swelling radiographs, you do see some of that profile, that thickening in that inside branch. So you can see that soft tissue swelling on the radiographs. But what I've shown you so far, the next step would be to ultrasound it. And why I'm showing you the ultrasound is that for consigners, it's getting more and more common to see vets show up with this ultrasound, along with their scope and their x-rays, especially at the first of sale. They're wanting to do a more thorough exam. The ultrasounds are more portable, they're quicker to start up, and it doesn't take very long to get a thorough exam. So if you look at this particular ultrasound in this horse, we can actually see the bone, the abaxial surface of the sesamoid. We can actually see a core lesion within it, and we actually see a little avulsion fragment off the abaxial surface. So we do have a tear in this particular suspensory branch. At the sale, for, as a vet, being the veterinarian for potential buyers, you're going to be worried about this due to the risks of re-injury. Even with stem cell therapy or magic cell therapy, PRP, there's still a high risk of re-injury. So, anybody have any questions? Yeah.
Are we seeing more medial or more lateral?
The inside, based on the, how horses are made up. The medial is going to potentially have more tension placed on it, so more medial.
This time of year, our babies have got tons of hair on their ankles.
It's tough.
So, is there anything wrong with clipping that for the sesamoid area just to watch, or do you feel like that hair?
That's being thorough. I think the thing to do is everybody gets their survey, screening radiographs, and they worry about, oh, I got an OCD in the stifle, I got a chip in the hock, I got 2 chips in the ankle. Worry about the sesamoiditis. Protect those horses. I always say that's the most important thing you get from your screening films, especially with, vets at the sale. You can clean up the chips, and vets will pass it based on 5, 6 surgery letters in there. That's fine. But sesamoiditis, since it's the vogue lesion, you gotta prevent that from occurring. So if you get sesamoiditis, ask your veterinarian, how do the sesamoids look? Really tell me, do I have much sesamoiditis here? And there's almost, they have to have some degree of it because they're gaining body weight. Those suspensory ligaments are pulling on those sesamoid bones. They're turned out in these huge fields, trying to keep up on the hard ground.
What's your ideal exercise regimen? Michael brought it up as well. Like we all know about the large fields and trying to keep up, that's a problem. We also know that, I think we know that forced exercise in small circles is not ideal either.
I agree, and I didn't mention that, and that's
So
the other.
What do you like to recommend, or if you can, or if the facilities are appropriate to it, what's the ideal size?
If I have a horse that does have sesamoiditis that was identified in March or April, and we followed it along, it's still there, that's going to be a horse that I didn't mention when you get into the sales prep time that you treat it as an individual. It's not like your herd, the group. You protect that horse. You don't put them through the same sales prep as you would most of your herd. Maybe you swim it to try to get that conditioning. And I see a lot of consigners, a lot of farms doing that. They send 2 or 3 horses to swim. The other thing that they're focused on, if you do get a profile, is they're focused on trying to get that profile away. And if that occurs a month before the sale, or because of the sales prep, which does happen, it's going to be tough for you to get that down. But the question about exercise is small paddock turnout, minimizing the sales prep, possibly swimming the horse. I don't use much medication. I wish we had a lot of those where you just hit the button and it works. There's not many of those drugs out there. Ketamine, sedation, some of those really do make a difference. But I don't recommend too much medication. You hear the aspirin, isoxaprine, Tildren, but I don't use any of that. I do use phenylbutazone. Phenylbutazone is an anti-inflammatory. I try to use it, especially in acute phases, as well as ice, try to shut down that inflammation. That's why you're getting some of that bone breakdown at that site, is because of the inflammation that's occurring at that bone tendon junction, bone ligament junction. Corticosteroids injections at the site, we sometimes do that as well, injecting triamcinolone at the site. Try to, with the same mindset, try to put that anti-inflammatory locally right on that spot. Any other questions? Okay. Easier for you up here.
Ooh, you guys can see me. I just kind of want to talk about that as far as treatment or what you do. I mean, I'm one of those people that do use aspirin and isoxaprine. I don't necessarily change their exercise protocol to begin with. If I have a horse that I consider has mild sesamoiditis, I leave it out in the field. I do put them on medication. For me, that's aspirin and isoxaprine. And I get asked all the time, do you think it really works? And I do believe it works. I think it takes a long time. I don't think you usually see changes for up to 90 days or maybe even longer. But I do feel like I see changes, and what I do is I keep them out in the field if it's just mild. If it's moderate, I'll change them to a paddock. But at 60 days, if they're getting worse out in the field, that's when I bring them back to a paddock. So I try to start out letting them be a horse, and then if I see that I can't, then I'll go ahead and change that. But I do think it makes a difference for me on what I see following these horses along. They're on medication. Part of the reason I say that is because I've seen some horses that haven't been put on medication, and followed them along, and I think I see a difference. The other thing, we talked about exercise. I do think exercise can very much harm some horses when they're trying to catch up with their buddies and be out in a big field. And the reason I say that is I've looked at a lot of commercial farms versus non-commercial farms over the years, and I definitely see an increased rate of sesamoiditis in my non-commercial farms. Horses that are out in 60-acre fields that never come up, that may have injured themselves to some degree and aren't babied along with it. So we definitely see a difference, and with that you usually get less OCDs and chips, things like that, but you have more sesamoiditis. So it's kind of a balance, I think, but definitely in the private sector where they're not commercial horses, we see more. So basically, I just want to go through a few cases, and I just want to show you some different things. Sesamoiditis isn't just the canals, and there's a lot of different visual aspects of sesamoiditis. Now, I wouldn't consider this sesamoiditis. Is this the pointer? This is the pointer? Okay. But you can see, if you looked at our other sesamoids, remember how they were kind of triangular? Now, see how boxy this one is? And that basically is that sesamoid was fractured as a foal, and then it's become elongated or has a different shape. But this particular one doesn't have what I would call sesamoiditis. You have, to me, that's a pretty normal vascular canal. So I would not be critical of this. What about anybody on the panel? I just want to show some, I mean, these aren't, our normal sesamoiditis, but it does have a different shape.
No, I agree. I think that's normal.
Okay. So just to show you different things. Now, this is 2 enlarged vascular canals. And to me, an enlarged vascular canal, like I said, means it's more than 2 millimeters. It has this caudal border, which is the difference between the paper that I did and the paper that Kane did, which Dr. McIllwraith cited. But 2 enlarged canals, to me, this affected horses at 2 years of age, but not at 3. Now, this looks pretty, this would be grade moderate sesamoiditis to me. How about anybody else?
Yeah, I would call it moderate.
So I think this is
I'd say
one.
moderate.
Go ahead. Sorry.
I'd
think
say
we all
moderate
agree.
as well.
And this is one I think would be severely discounted at the sales. But if you really look back at the research that has been done, these horses were affected at 2, but this horse, if you're just looking at numbers, raced normal compared to the rest, to the normal horses at 3. So I think, again, just like Dr. Rodgerson said, you got to make sure that you're not always pushing these horses and maybe trying to go to a 2-year-old sale. Maybe you do need to give them more time. But what it does is we're able to put some numbers on it and give people some risk factors. And what is the percentage that this horse is going to race at 2? Well, it's decreased than a normal horse, that we know. And this is one I just wanted to show for a hind limb sesamoiditis. And honestly, I would have considered this moderate. How about anybody else on the panel? Mild, moderate?
Yeah, moderate.
Moderate.
It's one of those ones that has a fairly large area. That, if you want to call it a grossly enlarged vascular canal or whatever you want to call it, it's fairly low. And in spite of that, I think that I would be a little bit more, me personally, I'd be more generous with that.
I think that's fair. Go ahead.
I was just asking Dr. Berk, because it's lower, you'd be more generous or more distal?
Yeah, I think so. Of course, you look at these in a sort of a micro fashion, and you start using a million adjectives to describe them. But if I just look at it as a whole and step back, I am more comfortable with that because of the location.
It's a hind leg versus a front leg.
No, it is a hind leg, and looks like a lateral sesamoid. But actually, this one scanned normal, which I was very surprised, and went on to race. I don't know, as far as in its career, how successful it was. I know it raced like 29 times, but it surprised me that it was normal on the scan. So I think it just is important because honestly, from a sales perspective, for me, this might, I might have said somebody moderate sesamoiditis and they wouldn't even want to scan it. So I think if you really are interested in a horse, or if you're selling it, I think it's important for you to know. So if you have some sesamoiditis, is that branch normal? Because then you can promote it as well. So there's different ways to look at that, but this horse was discounted at the sale, and I think sometimes wouldn't make it to that ultrasound stage. So if you can be proactive and get it there before it's at the sale, it benefits you. Now this is one I wanted to bring up just because this is different. There's ligaments, we talk about the suspensory ligament, but there's ligaments all over the sesamoids, okay? This is the inner sesamoidian ligament, that lucent area there, and you can see it over on here. And there's a ligament that goes in between the two sesamoids. The suspensory branch comes over here, the larger area here, but then there's also ligaments along the base of the sesamoid as well. So there's a lot of different areas that can be affected, and we might just call it sesamoiditis. But this is one, I mean, it's not a very large lesion, but how do you guys feel about this inner sesamoidian lucent area in the sesamoid?
You know, I see it so often that, and it never seems to be a problem, or rarely a problem, that it doesn't concern me an awful lot.
Anybody else?
Yeah, I would agree with that. I think that there's something that's probably different than that, which is necrosis of the inner sesamoidian ligament, but those horses are usually acutely painful, and that's, I think, a whole different deal. I see this as I don't know if I want to go so far to call it variation of normal, but basically it's commonly seen, and I don't attach any clinical significance to it.
It is one of these ones that's going to be tricky, though, because when you get this clinically in a horse in training or racing, they're not easily fixed. And you've got that osteitis, and you've got disease in the intersesamoidian ligament that Dr. Spike Pierce talked about. And I think that so people are always going to go back and correlate with the earlier change, but I've never seen any relationship established, and you guys are looking at them all the time, and it sounds like the consensus is that it's unrelated.
We rarely see a youngster get that problem. I agree with Dr. McIllwraith. It's just a racehorse, septic tendon sheath type problem, more so than seeing it in youngsters, weanlings, yearlings.
For me, the lesion is a little bit tricky because if it goes bad, it's real bad. And I have had one become clinical. And I think that's a problem with, where a lot of us come from is, if you have one case that goes really bad, you don't forget it. And that's why we need studies, and we have some studies, but there's a lot of different things that go on with the sesamoids, not just the vascular canals, and we obviously need to look at more places.
No, it needs to be followed up, because I agree, Debbie, this is digressing a little, but we have a huge problem. I do a lot of work on cutting horses, and at the yearling sale, they look at the condyles very, very intensely and even get ding horses on the base of flattening, and the bottom line is a lot of cutting horses injure their femorotibial joints. They're usually soft tissue injuries. They're totally unrelated to anything on the radiographs, but if you think you can talk would-be buyers out of that, it's hopeless.
Yep.
So once they get it fixed in their head, it is an issue.
No, I agree. And so just something a little bit different for you guys to see. And this one, I just wanted to show some sesamoiditis with proliferation, which that's where the bone actually, see how it's just coming up, and it's hard to see, but there's an outline, and it's not just that smooth outline of the sesamoid. You actually had the suspensory pull up the bone a little bit. And in the paper that I did, when I looked back at these weren't significant unless they had enlarged canals with them. However, I have to say there's so many of these that have suspensory branch desmitis when we scan these now as yearlings. So makes you want to go back and just look at that particular lesion. What do you guys think?
I worry that some of these are potentially chronic, that, 120 days previously, they could see a nice core lesion. Now it's kind of filled in. Typical ultrasound exam in the acute, it's, anybody could see the hole. But as you go further down the road, these things typically only look better and get better and fill in once that edema comes out of that ligament. And sometimes they're hard to find. But that bony proliferation, you're worried that was there some sort of insult on that, bone ligament junction at some point. And if it's weanling or yearling in January, February, maybe it occurred as a foal. But to me, I'm worried, it could be chronic.
Think that's fair. Anybody else want to say anything? Okay, I'll go on to the next one. And this one I just put up here because, you know, we talked about enlarged canals, and that's the one thing that we have looked at and can say that, well, in my study that affected performance, and then Jonathan McClellan's most recent study, they were horses that had enlarged vascular canals were 5 times more likely to have suspensory desmitis as a 2-year-old. So, but not always do they play that look of this is 1 enlarged canal, 2 enlarged canals. But if you look at this one, it's just kind of a generalized lucency in here and no really distinct borders to the canals. What do you guys think of this? And I don't have ultrasounds with this. This was purely because many times, which is most of the time, we're only given the radiographs to look at, and then the ultrasound is, you know, a possibility after we look at the films.
It's in the Kane study, we monitored this and we noted it. We called them sort of more cystic lucency, and we didn't really have the numbers that I think to have the statistical power, but we didn't show any relationship with later problems. It was graded totally separately from the vascular canal changes, and we didn't see an association.
Well, in my paper as well, I didn't see a difference going at the distal abaxial border with the lucency, but when you get down deep to that abaxial border, let me show you guys what I'm talking about. Right in here, when you get down to where the abaxial articular surface is, when they're that deep, that starts to bother me. And I would want to scan it and see where it is. But those deep lucencies bother me more, even though the abaxial lucencies did not affect performance, because I think they're a little bit different in the research that we did. And then finally, I just wanted to show you one that has, honestly, I would call that pretty much a normal vascular canal. But if you look how thick the soft tissue is from the bone to here, and that'd be one I would, just off of the films, would think that there's a suspensory branch desmitis and would want to scan it. And I'm one of those people that I only get to sit in the repository. I don't usually get to go out and see the horses, so I focus a lot on the soft tissue when I'm reading films. And this really helps me to decide whether or not I think I need to scan a horse sometimes as well. Because this particular case, I think I would need to scan, where I was really okay with the sesamoid. Any comments from you guys on sesamoid or the soft tissue?
No, I just think it's a good observation. You know, it's really easy when you're reading radiographs to just focus on bone, but you've got to constantly be looking at the soft tissue. And I mean, there's other examples of that, especially like in a, you know, in a hock where you're looking at a synovial effusion like a bog spavin, and it helps you to maybe go further, maybe even re-X-ray a horse if you're looking at an area where there's a lucency where there typically might be an OCD, and you know the soft tissue is going to, of course, unfortunately, that soft tissue profile might be there on the radiographs. It might be gone by the time you go look at the horse. There's been some steroid intervention there.
And then obviously if this was a spring survey, we would hone in on that, and that would be a great concern, that we need to follow not only the suspensory but also the radiographs, because they may change as you have inflammation in the suspensory branch. Oops. Okay, that's the last one of mine.
Let's see where we're at for time. At this point, I'd like to do a couple of things. A lot of our discussion in showing you these cases has been to try to demonstrate, number one, how we would approach looking at sesamoiditis, and as you can see, you know, diagnostically, we're not just looking at X-rays. We're more and more looking at soft tissues as well. And as a result of discussing these cases, you can see that we've talked about potential soundness issues, but I want to make sure that this talk is relevant to all the consigners. And so we want to just give some perspective on how sesamoiditis affects you as sellers. And it's obvious how it'll affect the buyer, and of course it's dependent upon the level of communication between the buyer's vet and the buyer as far as their level of risk. But it's a completely different thing for you when you're trying to present these horses. And there's been some discussion about following them from their spring films and how to properly manage them. And once you reach the sale and you have a horse that has more than just a mild sesamoiditis, something that may be a selling issue for you, I think we've talked about ultrasound for diagnostic purposes, but it's not uncommon anymore if you go the extra mile and you have a sesamoiditis case that's mild to moderate or moderate, to go ahead and have your veterinarian, the consignor's veterinarian, do an ultrasound exam. And if you can demonstrate that, in fact, that branch is normal, I think it does go a long way toward buyer confidence, and also for the buyers, the potential buyers, to understand that you're paying attention, you're aware of what you have, and that you're trying to present it in as transparent a way as possible. Any comments from the panel about that, selling issues relative to sesamoiditis?
I think what Dr. Berk said at the end, ultrasound, I'm seeing more, especially the better yearlings first to sale, where they're ultrasounding it before they go to the sale grounds. They know what the x-rays look like, but they also want to know what the ultrasound looks like. So if a vet shows up, they're pretty confident that, okay, he's going to find a tear or he's not going to find a tear. So it does, come into play more and more, and that's what the point I tried to get across, is that the ultrasound's pretty important in this.
What do you estimate, any of you here or all of you, the use of ultrasound when there's questionable lesions on the radiographs?
Well, I would say for me, in acting as a veterinarian for potential buyers, Debbie had already mentioned this actually, and sometimes if you feel like you're on the borderline, if something is if a sesamoiditis is so pronounced and your buyer is, let's just say they're buying to resell and you know that, there may be no point in doing an ultrasound exam, because the real question is, well, what's this sesamoid going to look like when I'm at the selling end of it? Now I'm at the buying end. Is it going to improve? And that's hard to predict. So, but there are many times where if anybody, buying a horse is like throwing a jigsaw puzzle on the table and then putting the pieces together, and there's so many pieces. And so if I say to a buyer, a potential buyer, this horse has sesamoiditis of a degree that I think we could get a better read on it if we'll ultrasound the branch, most of the time they'll say yes. So we're doing a lot of that now. But there are times where they'll say things like, I don't love that horse. I've looked at the pedigree again. I'm not really thinking that I want to go that far. And so, unfortunately for sellers, even taking away all the evil veterinarians, there are many reasons why people won't buy a horse. And so when you present the facts, sometimes they'll want to go further and sometimes they won't. So that's pretty much client driven. But I would say most of the time now, if somebody's gotten to the point where they're having me vet the horse for them, most of the time we'll go ahead and go the extra mile and do the ultrasound. We're doing a lot more of it. I think if I understand correctly, everybody at the table is doing more.
We do more of it than we used to, but I still think the radiographs, that's where basically most of our research has been, and I still make calls off the radiographs and don't have the scan. Just, I can give them the stats on what's out there, and oftentimes that's enough for them. The ones that I do is, I remember the one that Dr. Rodgerson showed you that had that lucency on the kind of almost like a chunk out of the sesamoid. Those ones almost always scan fine, but I still scan those just because, I tell the person, I think this horse is fine, but, and it's probably more for my comfort level than theirs, but that I think we should scan it just to make sure. But honestly, on a lot of the other ones, I still go off the radiographs because I have that data. I know which, I can give them percentages at least. It doesn't mean that the horse is going to be okay, and like you said, it might be, oh, I don't really want that horse anyway, you know? I mean, I think unfortunately, it gets, I think, the person more off the horse than necessarily they should be. And maybe I should be more proactive in scanning them.
Well, it works both ways for me, because there's a lot of people that will stay on a horse if the branch scan's clean. But I think the point that you made is a really good point, and it's a good take-home point for everybody here that's selling, because, you know, unfortunately, even the veterinarians that are competent and trying to do the best job that they can are branded as Dr. No, because it's perceived that we're looking for reasons for clients not to buy a horse, and I don't think that's true of anybody here. I know it's not true of anybody here.
I think that's really important, Jeff. You know, as Debbie says, that's where we have the data. And, you know, at the time that the cane study was initiated, that was funded primarily by Keeneland and also AAEP. And the problem was there is that there was 50% incidence. This is talking about all radiographic changes, but 50% of the yearlings, the 1,200 yearlings that we followed up, had something on their radiographs that some veterinarians would say don't buy, or this is a problem. And so we then got those data, and then, of course, since then, there was focus on sesamoiditis, particularly with Debbie and Larry's paper, and then the more recent ones out of Ocala. And we have that. But that doesn't mean we should be prospectively collecting our data on ultrasounds. And so in a few years' time, we'll have that information. Because you really got to go out through their 3-year-old year of racing. But that's just accumulated evidence. At the moment, the gold standard really is radiographs, because that's what we have the data on. And I know I'm repeating it, but it's really important. You know, there's been a lot of work put in. These studies are difficult to do. There's been a lot of work put in, and we shouldn't ignore it.
Well, another thing that Debbie said, I think, is really a good take-home point, and that is we're dealing with, and Wayne, you just said it yourself, we're dealing with percentages here. And so what if I'm asked by a client to vet a horse and it has a moderate sesamoiditis, they're not. What I can do is, based on these percentages, I can give somebody an idea as to whether or not they're at more risk by buying this horse than a horse without sesamoiditis. What I can't do, and what nobody can do, is to predict on any given individual horse anything. And I think that there's an important difference there that needs to be understood by buyers and sellers, is that what we're trying to do is to put horses into risk categories. We're not trying to predict on any individual horse what's going to happen. It just can't be done. And so when you take it that way, then you know, you hope to win more than you lose, but it's impossible to say on any one of these cases what would have happened prior to their racing or training. I'd like to just go ahead and open it up for any questions right now, and just so that everybody can hear. It's really hard to hear when you're back there and someone's questioning, so do we have some microphones that we could hand out? Pat? Okay, I won't forget you. Hey, Pat, down in front here, we've got another question after. Okay, go ahead.
Such a buzzword, sesamoiditis, and education of buyers and sellers is so critical. What can Keeneland, Phasig, and the CBA do to promote education so that it's not such a deal killer?
Panel?
Well, I think, you know, the information that we've got could be summarized into a layman version that a number of people could look at. You know, I think we've got enough information now that we could certainly provide that collectively, because you know, that's what the early studies did as far as the radiographic changes go. Like veterinarians who perhaps were less experienced than the people up here had something to go back to in terms of some lesions were clearly not a problem, or some radiographic changes. And so I don't know. My opinion is it's probably time that this this information gets put together in simple form. I don't know. What do you guys think?
I agree with that. I think it's education, though, as well, just on a one-to-one basis with your client. And I think that's hard until you know your client very well and what their level of tolerance is, because I think there's definitely a level of tolerance with sesamoiditis. But that varies person to person. So what's moderate sesamoiditis, even from a veterinarian standpoint, isn't always moderate sesamoiditis to another veterinarian. But how comfortable a buyer is with sesamoiditis also depends. So I think there's a lot of one-on-one that needs to happen, and I don't think that it's a bad idea at all to put this information together. I think it's a great idea. And then also, we as veterinarians need to be looking at some suspensory branches and putting something together to try to bring it all to one. Like there's Ramsden's paper out of Newmarket, and he showed that he just looked at 60 thoroughbred racehorses, and was it almost 9% had subclinical lesions in their suspensories. You know, and that's nothing that was clinical. They weren't lame, but it was close to 10%. So there are subclinical lesions that aren't bothering horses. If we can get more information and try to pinpoint that more so, that would be useful.
My experience since I've been here, I think people are getting more educated all the time. When I first got here, if you had an OCD and laterotrochlear ridge, you couldn't sell it. And then people kind of started to live with that. And then it was the spur in the knee. If you had an upper knee joint spur, you couldn't sell that. And now people figured, they can probably race okay, most of them. And now we seem to be more on sesamoiditis. So I think it's slowly, people are getting more educated. This is not very old since we've been x-raying, since I've been here, since they've used digital radiographs. So I think the longer we're doing it, the more educated people are getting, and hopefully the easier it gets to sell.
I think that also, there are many factors that go into making sesamoiditis, and Debbie had given her observations as far as where she sees the most of it, and depending on where you are, what type of practice, you're going to see different things. But one thing's for sure is that I'm not sure how to put this exactly, but overzealous sales prepping can be a contributing factor to sesamoiditis. So I think that some of it you probably can't avoid, and you're monitoring it with your spring films and trying to manage those horses differently. But at the same time, you don't want to be creating sesamoiditis by too much, in the history of the world, there probably has never been a horse that went in a tiny little circle for 20 or 30 minutes unless it had inner ear disease. And so by itself, without anybody making it do that. So I think that sometimes we, in an effort to get these horses to really look great for the sale, we're creating some of this. And I just think that that's just another factor that we need to be aware of.
One thing I've noticed in my work is that horses that go to the October sale here at Phasig have a lot less sesamoiditis overall than horses going to the September sale. I think some of our research just at Haggard showed that 35% of horses in the September sale had some degree of sesamoiditis, and 18% at an October sale had some degree of sesamoiditis. Anybody want to comment why they think that could be?
What do you think?
I think it's because they're older and more mature, and you're not starting them as early prepping.
Yeah, the prepping's less aggressive.
Yeah. Wait a sec. Go ahead, Serge.
I just wonder, you talk about percentages of horses with problems racing or performing or whatever it is. Has there ever been a study on horses that are technically clean at the sales? How many of those are sound race horses or versus horses that we come here, I guess, with blemish x-rays or sesamoiditis or whatever? What percentage of those perform or not? Would that have ever been looked at it, or can you make a correlation about it? Or
you can. Well, and there's various levels that it's been done, but for instance, the first study that the first big study that was done, the Kane study I mentioned, 81% of the horses raced. of all the yearlings that were looked at, the 1,200 yearlings. There's been some other studies that Debbie's certainly familiar with, where various levels of controls have been done. But when you do one of these studies, you've always got cases and you've got controls. People call that a cohort study, and so you know what the controls do, and there's always a comparison made between how many race versus not. So there is baseline data, and in some of the studies it's more sophisticated as to how many raced at 2-year-old, how many as 2-year-olds, and how many raced as 3-year-olds. For instance, in this, I turned my computer off, but in the recent 2-paper study out of Ocala, they had the exact percentages, which I could send to you, or we could, if you want the paper, I can't remember them exactly, but they had the percentage of the controls, because the majority of them were controls because they didn't get suspensory desmitis, how many raced at 2, how many raced at 3, and also what their earnings were. So those data are around, but as I said, the first paper that I was involved with, 81% raced. That's not necessarily at 2, but we did have it broken down. I just can't remember the figures.
Any other comments from the panel? Question?
Jeff, can we take that need for the simplifying as a volunteer from the panel to work with the plain and simple? We could have put together a booklet on this subject.
You can have the whole panel.
I think that would be a great way to summarize it.
You're going to get a public commitment here, right?
That was what I was working for.
No, I'd certainly be glad to help.
Yeah, and I think you have to remember, though, even between the two studies, it's a little bit of a difference in how someone views something as well, and their interpretation. So there's always going to be a little bit of a wiggle room for people on it, but obviously there's a lot that we could put into simplified terms and help people out. Yes.
Do we have to have cartoons with it?
We can have some simple diagrams. I think, putting the radiographs into diagrams is one way.
They're probably thinking they don't want to see another sesamoid.
Yes.
In a previous discussion, they were talking about testing for steroids. And this is a jump off of sesamoiditis. But you mentioned treating some of these horses with various things, corticosteroids. You might even have put other things in the treatment. How do you feel about the BHA kind of running a sword through things with their pronouncement that all those horses are off limits to race?
Well, with reference to sesamoiditis, you'd want to differentiate between anabolic steroids and corticosteroids. And, the initiative right now is for anabolics. So that really wouldn't play into this. Are you asking, though, if they did extend it to corticosteroids? Well, the whole thing is problematic because the initiative was really quite extreme to begin with. I mean, I have no problem with the idea of horses not being on anabolic steroids, but the way it was done, and when I was in Newmarket, I spoke to most of the veterinarians over there about it, and they had no involvement in terms of consultation either. So what's happened with the BHA is it's an unwieldy thing that's been thrust upon us that we're going to have to deal with. If it extended to therapeutic medications, other therapeutic medications like corticosteroids, what would have happened, which is maybe what was the intention all along, is to make American horses not marketable to the English. But, aside from that, I don't know what to tell you. Panel?
Well, a couple of comments because, we've touched on it, with all of the other three panel participants in terms of, like, I'm familiar, I consult for a client that at a farm that Debbie does the work for, and I see a lot of isoxaprine and aspirin mentioned, used and recommended, and I think it's good. You know, it's certainly not going to cause any harm. It's got rationale in terms of the fact that the vascular canals are indeed that. They got a blood vessel inside, and if you can perhaps alter clotting or you can dilate the vessel, that might be of benefit. On the other hand, there's other products like anabolic steroids that's been brought up where the regulations, as Jeff's just discussed, inhibit its use. Now, is it appropriate to ban anabolic steroids for the life of the horse? We do use them therapeutically for certain things in young horses. Corticosteroids, there's probably not much indication for them, at least intra-articularly, but there's certainly some systemic ones used. So I think you've got to be responsible as to what is therapeutic, and of course that leads to a lot of argument, but, you know, we could philosophize all day on it, but when you're using products like isoxaprine and aspirin, you're not causing harm, and that's meant to be the rule that we as veterinarians should follow. And some of the others, like my big beef, if we're going to talk about different products, is it's not anabolic steroids, it's children. Because the effects of children are so ill-defined. And if you go back to rationale and the potential to cause harm, there's a lot of reasons, reasons that you potentially can. Now, I do quite a bit of work in France, and every horse with a lucency in its bone gets children. And tons of it, and there's no follow-up data, even though it's been used for probably 10 years there. So we just got to take responsibility and validate if there is a good clinical indication, there's a rationale, and it's not going to cause harm, it's okay. But otherwise, no, it's not.
Other comments from the panel?
Hi. How might conformation be related or correlated to sesamoiditis? Like past foreleg conformation, pastern angles. Could you all mention if there's any correlation, or if you see any correlation in pasterns and sesamoiditis?
I personally think that I do. When I observe horses that are long in their pasterns or weak in their pasterns, I do think I see more sesamoiditis. You know, how to what degree, you know, maybe this is something they're going to grow into more than the moderate sesamoiditis as I see with that. I also think sometimes they don't improve as much as I would like to see through their yearling year because of differences in conformation. I think toed in, I'll see that as well. But I have to say, sometimes I'm seeing more lateral ones on the toed in horses than medial, which the inside branches seem to be much more the problem that we see in the race horses. But it's interesting, in Jonathan's paper, most of those, the majority of them were lateral branches, and when they looked at the 2-year-olds in Ocala. So it didn't mimic what we typically see on race horses coming in. But I do think, and I'm wondering, and he wondered in the paper and wrote that if, you know, left front toe in was a reason, because they were mostly left front lateral branches in his study. So I definitely think that they do play a role. Anybody else?
Yeah, I agree. There's definitely see a higher incidence of sesamoiditis in horses with long pasterns or toed in, toed out, for sure.
When you mentioned laying off horses or postponing training for 2-year-olds with moderate to severe cases of sesamoiditis, is there a stage in their life where sesamoiditis is no longer an issue?
If they have a branch injury, I'm going to try to lay off them. If they have moderate sesamoiditis, you got to potentially go slow and follow that along. But if you get a branch injury, it's almost like a bow tendon, where it's, you know, everybody knows what they're like. I mean, they have a high chance, especially in the racehorse, to re-injure themselves. It becomes more of a nagging problem. And then you have a lot of them out there where, you know, 3-year-olds, 4-year-olds, you see them come in for lameness, and they may come in for a knee chip, and if you further evaluate that horse, you'll see a sesamoid, you know, in the opposite hind leg that has sesamoiditis, mild to moderate sesamoiditis. Is that clinical enough to bug that horse where he's getting off that leg and breaks down in the opposite front and gets a chip? Who knows? But there's a lot of cases out there where they do prove you wrong, where you go and you look at the radiographs and you see moderate sesamoiditis, and you're like, you know, you found the diagnosis, and then you ultrasound, you see a tear, but the horse just keeps racing and working through it. And they'll prove you wrong, just, you know, like they do on throats and sesamoids. But if it's, you know, you have a tear and you see that and it's fairly acute and you kind of know when it occurred, and some of them just from one day to the next they have a tear. And if you know the time frame, I mean, I think you got to give them the time, same as you do for a bowed tendon, and to just give them 90 days, 120, I don't think it's long enough.
You know, you say instead of putting them in training as a 2-year-old, just leave them until they're 3-year-olds to start. That's not that there's a tear or an injury there. If you have sesamoiditis without the tear, and you just decide to, you know, rather than start it as a 2-year-old, maybe give it the whole year off and start it as a 3-year-old, is that a sensible option, or is it making a difference?
That's an option. I think the sesamoids are kind of like, they are dynamic. I mean, you may see an X-ray today, and you see changes there, but they can improve. If you manage them and you protect them, they can improve and they'll change. Now, granted, there's some horses, you're done. I mean, from a business standpoint, cut your losses. But if you don't have a tear and you protect them and you give them some, you know, try to keep them on the lighter side so they're not as heavy, maybe you just ease them into training, take your time, I think some of them have a very good chance to go and race. But if you don't know they have a tear and you start right off the bat as a 2-year-old, I think you have a high risk of re-injuring them.
Another question? Let's wait for the microphones just so everybody can hear, okay? Right behind you there. I'll get you next.
You're talking about conformation and some of the longer pasterns. What about, I guess, heredity versus environmental aspects of sesamoiditis? And are there any sire lines or something that you see that have more of a tendency to show these lesions than those others?
Not that I would mention publicly.
That was basically my question. If certain pedigrees tended to develop this problem more than others, or is that even a factor?
You know, when I read radiographs, I always put the stallion so that I can keep track of this in my head. And there are so very few, to me, radiographic changes that you can follow through any sire line. You know, my husband does a lot of scoping, and he can basically look at the name on the stall and say what the scope is going to be like almost before he goes into the airway. And that always made me really jealous. So I started always writing down the stallion name of every horse that I look at. And honestly, I have to say, I can't say from radiographs alone. I do think there are some conformational changes that predispose horses to sesamoiditis, but I can't say that I see, you know, sesamoiditis in a certain sire line per se. And there's very few radiographic changes you can say anything about for me.
Any other panel comments on that?
I keep harping on it for epiphysitis and sesamoiditis. Weight plays a role. And if genetically you got a horse that, you know, throws a heavy body style and you got a fine bone structure down below, you, in a growing individual, are potentially going to have problems. Same as in kids. You know, if you listen to the human orthopods, I mean, they're doing knee replacements on young kids because of their body weight. Body weight plays a role. And here in Kentucky, we have the problem. We have this beautiful grass, and they get heavy quick. And if you got a heavy body style and fine bones, watch them.
We've got time for a couple more questions before we break.
So what percentage of horses are we talking about here in central Kentucky that you're going to find some comment as far as sesamoiditis, both spring and through September?
I keep track of all the spring radiographs and percentages every year that I do. And moderate sesamoiditis, and like I said earlier, it really varies for me, from a private farm to commercial farm. If you're just talking commercial farms, I mean, your moderate sesamoiditis is 2% or less, typically. And your mild sesamoiditis can get up to 15%. Depending. Some of them will be more, but depending on farm. But it's a smaller percentage, I think, than what I think I'm seeing a larger percentage at the sale than I used to, which I think you guys alluded to that as well.
35% of horses in September sale have some degree of sesamoiditis.
Every veterinarian is going to be different, and a lot of for the sale, you're reading them trying to potentially evaluate what everybody else is going to say. Even though I might say it's mild, somebody else may say it's moderate, and you got to prepare your client for what other veterinarians are going to say. And as Dr. McIllwraith said, there may be some people that don't look at a lot of radiographs, but they're going to give their opinion, and it can create, waves of problems once that horse gets ready to sell. So everybody has a different opinion, and it'd be great to get everybody on the same page, but it's a difficult topic.
I just want to add one thing. Like in McClellan's paper, he looked at 3 different ways to grade sesamoiditis, and one was just a dichotomous scale, whether or not they were perceived as to have sesamoiditis. It wasn't graded on enlarged canals, and what was it, like 95%? I mean, it's a huge number.
92%.
92%. I was like, whoa. I mean, obviously we wouldn't be able to sell horses if we all felt as critical about sesamoiditis as when they were looking at those. But it was a very large percent of just sesamoiditis or no sesamoiditis that had it on their scale. So you can see everyone has a little bit of a different opinion. That's why we try to do these studies and show certain things that we can say, yes, this is sesamoiditis, if that makes sense.
Another question?
Do you think you are seeing more sesamoiditis at the sales because of better detection, or are you seeing more horses with sesamoiditis?
I personally think I have a little bit of a unique background because I was based in Ocala for a long time, so my primary job was dealing with young horses and training, horses that would leave Kentucky at the yearling sales and end up there and go into training. And for me personally, I have seen a lot more sesamoiditis than I used to. And again, it's multifactorial. So why that would be, I do think that there's an emphasis on prepping now that is much greater than it was a decade or two ago, that's for sure. And so that plays into it. I'm sure there's other factors that I'd be unaware of as to why, but for me, I think I see more now. Panel?
I do think digital radiographs brought it up to where you see more sesamoiditis. I think, but that is more the mild, or probably what a lot of people would consider more of an insignificant sesamoiditis. But I do think your more serious sesamoiditises have increased. And I do think a lot of that is probably, because we see the increases, due to prepping.
Question.
Do you see a variation from year to year on how much sesamoiditis you find it coming to the sales?
Yeah, I think it is pretty subjective, because sometimes I think so, and then not really. I can't say that boy, that's a bad sesamoiditis here. I can't say that.
Why don't we just take one last question, and it's about 4, and we'll close it down. Anything? Okay, well, thank you very much. Appreciate your attendance.